Two interesting talks. Initially, one is a talk on short stature by Dr. Warun Kumar, and next we have a talk on obesity, a medical and vascular disorder. To chair the session, we now request Dr. Mahesh Babu to lead on the stage.
Sir, thank you for your kind words of introduction, sir. Thank you. Good afternoon, everyone, and it's a post-lunch session. I thank Dr. Kumar sir for inviting me as well. So, without much delay, so the talk given to me is actually about the short stature, the overview about how the growth hormone can be used in the day-to-day practice, and with specific, the orientation regarding specific disorders where the growth hormone can be used and how we are using it. So this is a case that came to me, brothers and sisters, 6-year-old. We can see the height of this child. Here, the standard deviation score is minus 3.18. I will tell you about this. Basically, this indicates less than 3, which is going to be diagnostic for short stature. So the short stature is basically diagnosed by 2 to 3 parameters. One, we look at the height of the child, we plot it and find out how they are deviating from the normal or mean for that particular age. That is called as height stage, the height SG score. Second, we look at the height velocity, where every child will be growing at a particular pace in particular age group. For example, a child who is born, the baby who is born, the first year the length development will be at approximately 25 centimeters. The second year it will be half, it will be around 12 centimeters. So this is an expected velocity of the growth in particular child's development. So whether this particular height velocity is occurring, so that is one of the parameters. Third is actually the biochemical markers of the growth. Basically, the growth hormone levels. We look at the IGF-1 levels and the IGF-BP3 levels. So these are three ways we look at the height of the child and we diagnose short stature. We can look at this particular scenario. We can see the height of both the children are on the lower side. They are siblings, and we find the height is going to be significantly lower. And we look at the bone age of the child. It is again lesser than 2 years, more than 2 years lesser than what is expected. So that indicates there is a delay in bone age. There is a delay in the height velocity of the child, ultimately resulting in short stature. This is a pictorial representation. We can see both the children are underweight as well as their height is going to be on the lower side. We did an MRI of both the children. We found the pituitary to be on the hypoplastic. We did the evaluation of the pituitary hormones. We found the other hormones to be normal, but the hormone to be required for growth to be on the lower side. That is a classical isolated growth hormone deficiency that we see in the day-to-day practice. So this particular children, they definitely require a modality of treatment which result in improvement in the height of them. So coming to the core of the topic, basically it all started some 50 years back when a person actually had the motto to improve the height by using some methods. So he used a lot of purified extracts from pituitary, and then they started utilizing it in a different way and found that there was a high potential that it was actually able to give to the children. So there was after 1985, there was a huge rise in the fear. Basically, the crucial Jacob disease, which is again transmitted through the tissues. It's again, degenerative disease of the CNS. There was a huge rise in the, concern regarding the growth hormone therapy. So after these, there was a downfall regarding the usage of growth hormone therapy, but still now, over the last 2 decades, we have a rise in the usage of growth hormone because of its purity, because of the upcoming overall methodologies of the manufacturing. So, to highlight why the growth hormone is going to be useful, we can see a lot of factors that is going to have an impact on the growth hormone secretion. And this growth hormone has multitude of effects. It's not just the growth of the children; it has benefits not only in the growth, it has implications in the metabolism as well. If you summarize the effect of growth, it has the importance of linear growth, it improves the linear body mass, it is going to have lipolysis, it improves the bone mineralization, fat mass is going to be on the lower side, protein mass is going to be higher. This is one of the mechanisms why it is being used as a doping agent. it actually has an altered insulin sensitivity, again predisposing for insulin resistance as well. So these are the effects of growth hormone. So this is a pictorial representation where you start looking at a child with a normal growth hormone and a child with a abnormal growth hormone. We see that there is an decremental, growth of the child who's having growth hormone deficiency. So that is the plotting. We see that every year we find that the growth to be on the lower side for a child who's having growth hormone deficiency compared to a normal children. So if you look at the prevalence, it's around 1,000, 1 in 4,000 to 10,000. But what will happen if you have a growth hormone deficiency or if the child is not growing well? Their growth will be retarded. Short stature is the imminent effect. But during the days of development, they can have a natural tendency to be on the lower side of developmental. So they have developmental delay association as well. So by the child who's reaching the adulthood, most of the children does not require the growth hormone therapy, and almost most of them will be stopped. And when you have a pituitary cause, where you have a pituitary deficiency, in some certain scenarios we tend to use the growth hormone in the long run, but otherwise we stop the therapy at the when the child reaches adolescence and adulthood. So, what is the role of growth hormone? Whether there is an implication or improvement when you are using growth hormone? This particular questionnaire, which was used when the patient were receiving growth hormone, they showed that there is a quality of life improvement when the child is receiving growth hormone therapy for a period of 1 year duration. But what are the drawbacks of using growth hormone therapy? The burden is the injections. When you say the injections to any child, the child will be taken aback. So that is the main important implication. That is one of the implications where the dropouts, the poor adherence have come into the picture, and we have so many formulations are available where we can utilize those formulations for improving the adherence as well. So the growth hormone therapy, Maurice Rabin, he is the one who pioneered. He injected growth hormone in multiple people, and he showed that there is an improvement. And this particular incident was a game-changing event in the history of growth hormone therapy, where he showed the betterment of using growth hormone, and then only the growth hormone therapy was being highly replaced. Initially, it was used as an intramuscular once a week and twice a day, and then it gradually was increased until it was shown that if you are using daily, there was a clear improvement in the growth hormone response. So, what you get out of using growth hormone therapy, of course, improvement in the linear growth. Apart from that, there is an improvement in the CV function and lipidological status. So the patient will be having a reduced the cardiac risk. The improvement in the quality is obviously noted for most of the children. Their playfulness, their appetite, everything is going to be on the higher side when you are using growth hormone replacement therapy for a child who's definitely requiring growth hormone. So the growth hormone improves the growth of the children, particularly if you are using it in a nocturnal phase. Particularly when you are using it in the night time, the response is going to be much more higher because of the physiological rise in the growth hormone levels during the sleep. And the effect actually waves off. If you look into the curve of using growth hormone therapy, the initial first year, the response will be between 8 to 10 centimeters. And the next year, the number of centimeter response, the height velocity response, where the growth hormone is going to be utilized, they start coming down. Maybe it is part of the growth hormone resistance that the child is mounting against. So first year of treatment, you get the best response, and then there is a seasonal variation as well. So what do you do when the child is crossing puberty? So these are the common scenarios in the day-to-day practice. So the child is started on growth hormone therapy, and you are continuing growth hormone. But what the child is going to, once they cross the puberty, what you are trying to do? Once the puberty is there, there's a state of resistance that the child is able to mount against. So there are studies, there are individual studies, they show that there is not much of a improvement when you are using at a higher dose of growth hormone replacement. But the RCTs have clearly pointed out that if you are using a growth hormone level of on a higher phase, for example, this particular trial, they use 0.7 milligram per kg per week versus 0.18 to 0.35 milligram, approximately doubling the dose. It actually showed a higher height response than a child who's than a puberty child who's receiving a smaller dose. So puberty is one area where we need to be always cautious you assess the child every now and then regarding whether the child is going to have attaining puberty. Then those are the scenarios where we are supposed to utilize the higher dose. So these are the FDA approved indications. We can see by the year which was recognized as an use, starting from the growth hormone deficiency. Now we have a lot of syndromic causes where you can use this growth hormone for utilizing it for improvement in the height of the children. So particular focus, the Turner syndrome, which is very commonly seen in the day-to-day practice, primarily the SGA. SGA is one of the territory where when the child is not improving after clear assessment, the SGA is one of the territory where the growth hormone has been implications in the improvement in the overall the metabolism as well as the height of the child. So again, what we try to achieve whenever we are trying to use growth hormone therapy. So when the child is normally growing, we can see the black curve. It is going to be the phases where the child is going to develop. But if the child is having deficiency and you are putting the child on a growth hormone replacement, so there is a dip where the growth hormone deficiency is implicating. And once the child is receiving growth hormone, there is a catch up. That is the initial 1 to 2 years of giving the growth hormone. And then once the child is continued on growth hormone, that's a maintenance phase where there is a plateau. And once a puberty is there, there is a pubertal spurt that is occurring into the child, because the child is going to be, the gonadotropins are the main determinants of the growth hormone levels during the phase of puberty. And this particular puberty will cause the spurt, and then there's a plateau again to the adulthood. So these physiological states are ideally mimicked by giving growth hormones at this particular phases, and then we are trying to catch the adult height as much as possible. So that is the ultimate target of using growth hormone therapy in the practice. So that is the transition phase, the initial phase where there is a steep rise in the growth velocity, and then there is a transition that is occurring, and after that the response to the growth hormone therapy usually wanes off, and that is a point of transition. And once a child is achieving the peak bone mass at the puberty, we are supposed to consider stopping, reducing the therapy and stopping the therapy. So growth hormone therapy is actually the main main thing that is going to have a huge implication not only at the height of the child, but also in the overall metabolism of the child as well. So in case of a GHT, treatment is initiated and the child is followed up every 3 to 6 month interval, so that we follow the child regarding the response to the therapy, as well as we monitor for the certain side effects of growth hormone therapy, which is again a very important thing that we all need to be aware whenever we are starting therapy. So while we monitor every 3 to 6 months, we look at the child's height velocity. Every 3 to 6 months, we measure the IGF-1 level. Now the recommendation is clearly pointing out that an IGF-1 based growth hormone therapy is the one that is we need to follow, so that we avoid the complications out of the growth hormone therapy. So we keep the IGF-1 level at the upper of the normal range, so that we prevent the complication that is getting arise. And free T4 and cortisol levels are done every 6 monthly, and particularly with the patients on multiple pituitary hormone deficiency, cortisol should be assessed regularly, so that when the child is getting a growth hormone therapy, we keep the cortisol to the lowest possible cortisol levels, so that the child does not have poor response to growth hormone. Because when you are using a higher dose of hydrocortisone, the child may not grow to the particular potential requirement. So what are the predictors? Age at which we start the therapy. For a child who started therapy at 3 to 5 years of age, compared to a child who started therapy between 11 to 12 years of age, there will be a difference in the overall the response to the growth hormone therapy, because the later we start, the poorer will be the response. Second, severity of growth hormone deficiency. If the child is having a huge, higher deficiency of growth hormone, even the presentation at the newborn phase, their response to growth hormone therapy will be at the highest compared to a child who is having a partial growth hormone deficiency. Dose and frequency. If you are able to titrate frequently, you are able to achieve the IGF-1 at the near normal level, then that is the phase that is required to have the highest response to IGF-1, growth hormone level. Genetic potential and bone age of the child when the child is being started therapy, that that also determines the response to growth hormone therapy. Inadequate responses are also noted, like insulin. When you are using insulin, we find there are patients will not develop the euglycemia. Similarly, growth hormone, when they are started, they don't have response in certain scenarios. Particularly injection phobia, where the child does not adhere to the therapy. Poor adherence is one of the important factors we need to always rule out whenever we are seeing patients with the growth hormone therapy. So concurrent GHI, the neutralizing antibodies, which are all very rare nowadays with the recombinant gene therapies, gene technologies, and when they have hypothyroidism. Why hypothyroidism has been clearly focused? Because when you look into two endocrine disorders which can have an implication with the growth hormone therapy, one is hypothyroidism, second is adrenal insufficiency. Both the therapies should be made in such a way that we don't have the negativism due to the therapies. For example, you titrate the dose of thyroid hormone, you try to keep the T4 levels at the higher level so that we can have a better therapy. Similarly, for a hydrocortisone dose, we keep it at the smallest possible dose so that we prevent the patient to develop a GH resistance. So these are the two instances we need to keep in mind whenever we are using growth hormone therapy in these endocrinopathies. Duration of therapy, we use it until the growth velocity due to the growth hormone therapy is falling to less than 2.5 centimeters per year, or the child is achieving the adult age or adult height or the desired bone age or the desired adult height. So these are the indices where we stop or titrate and stop the therapy of growth hormone in the children. The challenges are also faced in many of the children. These are the particular challenges, but for most essentially is the titration as the adherence, because when we start the therapy, the cost of therapy and the cost of follow-up are all the important implications why the patient does not follow the therapy properly. And certain things that we need to keep in mind, particularly with respect to the thyroid levels. The thyroid function test is serially done every 3 months or 6 months once, because when you start therapy, the T4 will be on the lower side. Because of the T4 to be on the lower side, we need to have considerations whenever we need to try to use thyroid therapy in these patients when the levels are very low. And hydrocortisone, I told you, we need to keep it at the lowest possible dosage so that we don't prevent the children to develop complications. The patient adherence is an important implication whenever we are trying to see. So some of the specific conditions I would like to point out. First and foremost thing is the growth hormone deficiency, very well documented, and 35 years of experience is there. Lot of studies have come out. Lot of studies in respect to the previous daily dosing of growth hormones as well as the weekly regimens of growth hormones available with respect to growth hormone deficiency, and clearly pointed out that these should be the first line of all the growth hormone therapies. The starting dose, it's 0.025 to 0.05 milligram per kg per day, and this is all weight based. And once you start, you titrate with the IGF-1 levels. Because IGF-1 is made as a biomarker, it is very crisp and precise so that we don't have the complications out of using growth hormone therapy. The ISS is one of the FDA approved conditions for the improvement of height velocity, and you tend to achieve the betterment whenever we are trying to analyze early and we start the therapy early in these people. And particularly with respect to people who are attaining puberty early, when the patients are started on growth hormone therapy, they tend to develop puberty early, so that when you are trying to see these children, we are definitely trying to suppress the puberty by using gene analogs, and along with the growth hormone therapy, particularly when the child is developing puberty, we are supposed to stop it, because this response will be poor, and the estrogen which is coming out is going to worsen the growth hormone response as well. So that is one of the things that we keep in mind, and we start therapy as early as possible. Turner, IGF-1 resistance is there. Growth hormone levels in these patients will be normal. We need to keep in mind because when you look at the growth hormone levels, we don't decide these. So initiation of the people with the Turner syndrome, when you look at the curve, when the child is falling by 5th centile below the normal for that particular Turner child, definitely we are supposed to start therapy with for growth hormone therapy. Similar to it, Noonan syndrome, we know that Noonan and Turner are morphologically the same. So they will be definitely benefited whenever we are using growth hormone therapy in these patients. We can see from this trial, when the child is put on growth hormone therapy, every year there is a definitive improvement in the growth of these children. SGA, approximately 10 to 15% of the children who are failing to improve will have the benefit in using it. And we need to keep in mind, when the child is put on growth hormone therapy, we are supposed to monitor the puberty. CRF, that is a chronic renal failure, is one of the implications that have been coming up in the recent past. When the child is having a prepubertal growth delay, when the child is on either conservative therapy or dialysis, when the child is put on growth hormone therapy, there is a definitive increment that is being noted in the height. So the responsiveness depends upon the renal function of the patient and the metabolic response. For example, the weight of the child also decides the response to the growth hormone therapy in patients with CRF. Achondroplasia, skeletal dysplasias, they tend to be variable in terms of the response. I have child with achondroplasia, hypochondroplasia on growth hormone therapy, very weak dyschondrosis on skeletal, growth hormone therapy doing great. But the dose of therapy usually will be around 2 to 3 times the normal growth hormone deficiency child. So we need to keep in mind, follow the child properly so that we don't come across these complications out of the growth hormone therapy. Prader-Willi syndrome are one of the common syndromes where we use growth hormone treatment. Coming to side effects, the initial concern was viral transmission and the antigenicity. Because of the preparations right now, we don't find much of this antigenicity out of using growth hormones in the latest genre. Cancer risk is one of the important implications that have been coming up in the literatures. The previous malignancies, if you have a history of radiations, then these are the children who will be at risk of developing cancer. Otherwise, the rest of the children does not develop it. But particular syndromes, neurofibromatosis 1, Fanconi, the Downs and Blooms will be having higher risk of developing malignancies. So these children should be followed up properly so that they need to be cautiously used with the growth hormone therapy. As much as possible, if they don't have these risk factors, there is no clear evidence to have implications. There are anecdotal reports to point out there is an increased risk of diabetes mellitus when the child is being put on a long term of growth hormone therapy, but we don't find it in the daily practice because of the dose that we follow it up. The intercurrent illnesses and use of growth hormone therapy, there is no requirement to stopping growth hormone therapy when the child develops fever, but if you are stopping it, definitely you are supposed to monitor glucose because they develop hypoglycemia doing this. Benign intracranial hypertension, very commonly seen when you are starting therapy, the child will develop a headache and blurring of vision. Just stop the therapy, start with a lower dose. This is a main treatment for benign intracranial hypertension, and these are the other side effects due to it. Mitogenically, we don't find reports of recurrences as well. To conclude, the indicated patients require growth hormone therapy and they should be used judiciously so that the child's growth, the metabolism, everything will be better with the use of growth hormone therapy, and keep cautious in certain groups where they can have higher risk of malignancies. Thank you, Anna.